Welcome, everybody. I think we're going to try to keep with our principle of starting on time. I'm Peter Wayne, and I'm the director at the OSHA Center, and I'm pleased to welcome you all to the next installment of the OSHA Center for Integrative Medicine Research Grand Rounds. We're in our new phase where we're alternating every month between research grand rounds and clinical grand rounds, and this month we're going to be doing research. And I have the privilege today of introducing one of my dear colleagues and friends, Dr. Chenchen Wang, and also some of her junior mentees to join us today for a presentation on Tai Chi for osteoarthritis and rheumatological and musculoskeletal issues. Dr. Wang is a very distinguished researcher in this field, one of the leaders in research in Tai Chi and musculoskeletal health. She is an associate professor at the Tufts School of Medicine and a distinguished recipient of a number of NIH grants, large RO1 scale grants, as well as this distinguished mid-career award in mentoring. And she's had a number of seminal papers published in the New England Journal of Medicine and the Annals of Internal Medicine and a number of other really landmark studies. So we're really pleased to be hosting her today. Joining her are two of her mentees. Augustus Lee is a postdoctoral fellow at the Center for Integrative Medicine, and Dr. Kieran Reed is a junior scientist in nutrition, exercise physiology, and sarcopenia laboratories at Tufts University. So without any further delay, please join me in welcoming our speakers today.
Good morning, everyone. Thank you very much, Peter. It's such a great pleasure to be here and discuss and share some information for this important topic, chronic pain management. And chronic pain management, and this is such an important issue. And last year, and we all know where our nation faces a great danger for opioid epidemic. And last couple of months ago, last year, in November, and we have the big conference in the Virginia and organized by VA, DOD, and NIH. And for this 2 days conference, we have discussed a very important topic, how to use non-pharmacological treatment and non-opioid alternative treatment for pain management. And these 2 days, I was assigned to the group of the exercise and movement therapy group. So after 1.5 days, the literature review, and we concluded we didn't find sufficient data to come out to a solid conclusion in this field. So this field is really still just the beginning. We have a lot of work to do. So for this talk, I really like to stimulate ideas, give some suggestions, and let's discuss this, how to improve this field, to help our nation for pain management. So I also invited my 2 talented young scientists from Tufts, and they did a wonderful job for data analysis and from large trial. Because the field, the NIH, the NCCH, one of the most objective next 5 years to increase workforce. How to increase workforce? We need a lot of young investors, young scientists interested in this field to work together with us and for chronic pain management. So for this talk, since this, I'm going to, and we will follow the following 3 portions. The first, I'm going to overview the challenging and opportunities in the field. Second, describe the chronic, describe the randomized control trial of Tai Chi, my body approach for pain management. In the last portion, we'll discuss how to integrate and this approach for our clinical practice. So since this is a grand round, I'm going to start it about a case of patients, Mary's story. And Mary's story was published in the New York Times in 2010, is one of our study participants. And Mary is 59 years old from Lynn, Massachusetts. Her initial symptoms included, it hurt me so much. just put my head over my head. Sleeping was difficult. I couldn't walk half a mile. There was no pleasure to life. I was an entire mess from head to foot. And her physical examination included multiple 10 points and was severe depressed. Mary rejected many kind of medication due to side effects, and she also tried physical therapy, swimming, and other approaches. None of approaches works for her. So how can we help our patients like Mary? So this chronic pain and such chronic pain syndrome has been, and we deal with our rheumatology clinic, primary care clinic, every single day. So how can we do better job and to help patients to manage this chronic and pain syndrome? So chronic pain really is global health challenges. I went to China and give talk and last year on the airplane. So the American businessman sitting next to me, and he told me he took opiates for his low back pain. How much he's suffering, he couldn't sleep. He said, "What are you doing there?" I said, "I'm going to go to China, give the chronic pain talk." He showed me all the bottle medication and the medication he took, and he said couldn't sleep because of the first class. And I saw him the whole trip. He turned back for this how much suffering. So this is a very good example for almost 20% of people and around the world has chronic pain. It's cost our nation $635 billion a year in medical bill. 4 million American people a year are prescribed long-term opiates. This published in 2011. Actually, it's the more and more now. We know how many people died because of the overdose opiates. So in absence of the pharmacological treatments, so the popular press Time magazine and featuring the big story, Understand the Pain, a couple years ago, the reporter interviewers, the mainly focused question, beyond the drugs, how alternative treatment can ease the pain? And the interviewers. So let's look at. So the NCCH went for Dr. Nayan and other people and did the national report review and the national health statistics report, and they find the patients in the U.S. patients use Tai Chi, yoga, Qigong increased linearly across 3 time points. You can see from 2002 the 5% and 10% 2012. So another interesting report from the Peter Gloria and other people's study, they find that people with chronic rheumatic pain most likely to practice Tai Chi. It's really interesting. So yesterday I put these slides. I think one of my interns put these slides. There's many Tai Chi studies since 1999. This all the systematic review. So the first review published in 1919, and you can see 2013, 24 systematic review on Tai Chi. So right now, every week I get invitation to review Tai Chi literature, Tai Chi review. The review is especially China, they like the review and the factory. So constantly ask me to review the Tai Chi literature. There's really not many studies. Why review by review? I don't know why it's continue review. So we need to have some high quality primary study, then review. So I believe in 2007, a 15 review will come out again. So let's see the review evidence. In this study, it concluded Tai Chi provide significant evidence for clinical outcome for hypertension, for osteoarthritis, and COPD. A lot of work did by Peter, Gloria, and me, and across the country. But they also mentioned a firm conclusion cannot be drawn due to methodology limitation and insufficient number existing study. We know this, the insufficient study, so I suggest do not continue to do some review, necessary. So those also the NCCH group also they did this study, evidence-based complementary approach for pain management in the United States, and they found strong evidence right now for Tai Chi and acupuncture for knee osteoarthritis. the weak evidence Tai Chi may assist those with fibromyalgia. Because a lot of work did in our group, so I'm going to use this example and illustrating to what our study looked like, the evidence-based. In the past 2 decades, our team conducted Tai Chi, many clinical trials, Tai Chi for rheumatoid arthritis, osteoarthritis, and fibromyalgia. And the fibromyalgia paper published in New England Journal of Medicine has been claimed to be one of the papers most likely to change clinical practice. But I don't know, yeah. So also we conduct many systematic review. And now I'm going to briefly review the results from these 3 trials. First, I'd like to describe these 3 conditions: fibromyalgia, rheumatoid arthritis, osteoarthritis, to non-rheumatologists. I saw Ivan here. I know this is not for Ivan. Ivan is a rheumatologist. For non-rheumatologists, let's first review the fibromyalgia, why we do this. And the fibromyalgia was initially termed about fibrositis by Dr. Gawar, a neurologist. And the pathologists think the fibromyalgia is the inflammation of the fiber tissue of muscle. But during next century, we couldn't find any information in the fibromyalgia. So current understanding of the fibromyalgia is a central nervous system pain deregulation. So this concept has been well established in this classic neuroimaging study. So neuroimaging study, they compare the healthy control in green and the fibromyalgia patient significantly increased brain region blood flow response to pain. So the study also, this concept also established this pathway. This is a pain pathway. You can see it's normal. The pain stimuli applied to the skin and the muscle. So the first come to transmitted to the spinal dorsal hall, then project to the brain. So if we take a close look to here, so we can, in the normal patients, and some of the neurotransmitter substance P or the neurotransmitter such as glutamate are normally released. For fibromyalgia patients, it's hyper-excitable because this for fibromyalgia patients this to response to the painful stimuli. So this has been demonstrated why fibromyalgia patient so difficult to treat. Because first, we don't know the etiology, and physicians often skeptical. We could not find objective measure for this chronic pain syndrome. There's no causal explanation between this and the limited treatment option. So now let's move to osteoarthritis. Osteoarthritis is the most prevalent chronic joint condition. And historically, disease is understood by damage and cartilage and bone. But the current understanding is it is the central mechanism, central nervous pain and mechanism play pivotal role. So this means, and the central factors may more superimposed among more traditional periphery factors. So lead us to treat patients more broad and flexible approach to diagnosis and treatment. So for rheumatoid arthritis, even more and complex from immune response to develop to pathological inflammation is long course, different phases. Also has a patient, most patient died of comorbidity, and the cardiovascular condition is the mainly and caused mortality. So for this fibromyalgia, osteoarthritis, rheumatoid arthritis, all this chronic condition. So we can see the pathological basis of this chronic condition really multifaceted. So based on current theory, genetic factors, biological, environmental factors, multiple interrelated physiological, biological factors really and lead to pain, fatigue, depression, anxiety, and poor self-efficacy, sleep disturbance, and poor quality of life. So for this and a very complex situation, can we use one and target to one one clinical symptom is no, because we have used multiple component. Tai Chi, mind body exercise, maybe play very important role in this pathway. That's I learned from Peter. Peter did a very nice review about this kind of multi-component stuff. Yeah, we signed this paper all the time. So now I'm going to to show what our patient did, and many people ask, what do you do, and for these patients. So I'm giving you a little bit. We use 10 forms, and for patients, easy to learn. And okay, now let's go back to our evidence. There's some debate I present to one of the Tai Chi master in China. Tai Chi master, the group, Tai Chi master asked me, what is Tai Chi? Since the patient doesn't not practice, what is Tai Chi? So I just read one of the famous book on the table, because the table said, no one knows what is Tai Chi. Tai Chi is the principle, the state of mind, is spiritual, is emotional. So she asked, what is Tai Chi? I said, this book is just talking about what is Tai Chi. Actually, for patients, and without any knowledge from different background, to come out of class with chronic pain, and come to our class with 8 weeks, we use this principle, changes their life. This is amazing. So, because we are not trying to help patients to become Tai Chi and champion, and we not compete, but this really for treatment. I'm emphasize where this is for treatment. So now I'm present some results from our publication. The first publication interesting published in the JAMA Archive in Medicine is 2004. Actually, we studied this 20 years ago, 1997. I was training my rheumatology fellowship at McGill. So I started work on this paper. One day I saw one of mentor in the evening. I said, where are you going so late? He said, I'm going to Tai Chi class. So I'm to Tai Chi class because he has COPD. So I never realized that's changing my career after his sentence. So then we went to Tai Chi class. We went to China, collect data. This paper took me 5 years. So in 2004, we published this paper. I bring this paper from McGill here, and take 5 years publish this paper. This become very popular and interviewed by 15 and international media. I don't understand why this so big deal at that time, because we really study different chronic condition and about the health outcome in patients with chronic condition. So try to understand the psychological symptom. So in 2010, we also reviewed Tai Chi and on psychological well-being. And we find the Tai Chi on psychological well-being and reduce anxiety, depression, and the mood and improve quality of life. So this based on all this publication. So in 2010, we worked trial published in New England General Medicine. So I went to Germany, gave a talk. People said, do you know the editor-chief in the New England General Medicine? Why is the 1660 patient you can publish this New England General Medicine paper? So I said that you didn't realize that this is our 20 years work. This is not the right way. And so this paper, although very, and I know Gloria write a very nice editorial for this. So although it's a very simple study, but it's a lot of things that belong very complex concept inside. So I want to show you a little bit about this. We use Young-style Tai Chi 1 hour twice a week group session for 12 weeks. Every sessions include warm-up review, Tai Chi principle, meditation with Tai Chi movement, breathing technique, relaxation. So you will see, and you already see what we did. So this picture is in our Tai Chi, one of the Tufts conference room. We use this for many years. For patients, especially for patient knee pain, I went to talk to China. A lot of people ask me, Tai Chi, a lot of people practice Tai Chi many years, did knee surgery. Tai Chi, and usually the injury knee, this doesn't make sense. So I asked this question to many Tai Chi and the instructor, why is patient injury in the knee? Because and they said, well, they didn't do right, Because for this patient, we specifically pay attention to, and the patient, if I have knee problems, they can sit on a chair. For attention control group, so this is our rheumatology and the room, so you can see a lot of people. We also do similar session twice a week, and session include pain, knowledge, diet, nutrition, physical, mental health, fundamental stretching exercise. So for control group, recently we did a comparative effectiveness study. You can see the physical therapy as standard physical therapy. This is Megan in our Tufts Medical Center. Physical therapy, usually we use consistent, our current guideline, 30 minutes after session, and for twice a week, 6 weeks, because insurance only pays 6 weeks. And we just use this design. And also personal therapy to address specific treatment. So it has a 6 week and at home rigorous and moderate exercise. I put the design first, later we discuss later. So, and from here you can see, and the outcome measure usually at our Tufts, and this Dr. Kirsch is my colleague friend. You can see the 2000 and Dr. Kirsch already worked rheumatoid arthritis study, what he looked at very young, right? So osteoarthritis study, 2005, he looked at the middle age. Then he's a gray hair. Over the past 15 years, he worked with me. He said, I don't like you put my gray hair there. So I just said, because our work as many colleagues and friends work many years with me, I present here is not my work. It's all my colleagues' work, And then for this, the fibromyalgia study, which is the main results, and the top curve at the control group, and the bottom Tai Chi, you can see at the 12 weeks Tai Chi group, control group is a 10-point mean difference change between baseline, Tai Chi group 29, the mean difference is statistical significance, this fibromyalgia and results. Also, my friends and Kim Jung from the California, and he also published a similar Tai Chi study for fibromyalgia study. So initially, he's actually the PI is not her, and is named Peter. So the Peter get this R1 grant, he passed away. And also I contacted him, he didn't respond. I said, what happened, why he didn't respond? So then he passed away, then Kim took this project. He also was published later than after us. And so the Kim's study, they measure difference, and they measure a lot of function, mobility, objective measure. You see Kim get the similar results, primary outcome, FAQ, also secondary outcome, the sleeping, and pain, also objective balance measure, and function mobility is this Kim study, exactly same thing like we did. So now I'm passed to osteoarthritis. We just finished the rheumatoid arthritis. For osteoarthritis in 2009, and we published the pilot study. The pilot study, you can see, I just briefly overview what is the main results. You see at the 12 weeks. So most patients in Tai Chi group has significant reduction in pain. And patients continue to practice Tai Chi and also get significant improvement, but still get improvement, but not as much as control group. This is our pilot study again. So the last year, we published a paper in the Internal Medicine. Actually, look at it, and this paper published easy, but it takes 1 year writing and 6 teleconference with annual internal medicine and statistician, and again to takes 2 years published. It's very painful. Yeah. So the design is a randomized control 15 2-week single comparative factor trial. We studied 204 participants with symptom knee osteoarthritis. So it can 53% is white. It's the most patients, and it's non-white minority. So Tai Chi group I just mentioned before, twice a week group session, use standard physical therapy, and because Dr. Mauro Alverson, he's a physical therapy expert in the country, and he supervised physical therapy group. So compare previous and the slides you can see, and compare physical therapy, what are our results? Our results different, right? Because you can see, and both group significantly improve, reduce the pain, improve, and other health outcome. So this is very interesting. And we're very surprised. In our hypothesis, we think Tai Chi better than physical therapy. It is not. There's no statistical significant. This reason I haven't got published in New England Journal of Medicine yet, because they said, this the not significant results. They like published the more positive results. Yeah. So for secondary outcome, is also there's no significant differences among pain, physical function, patient global, and 6 minutes, 20 minutes walk test. So for psychological health, you can see Tai Chi group significantly reduced depression, and as of citizens' physical components, this is interesting, right? So for this study, and many people ask medication. So medication, both groups were generally reduced at all follow-up points in both groups is not statistically significant. What is the strength of this study? So this is a robust, rigorous conducted randomized control comparative effective trial with 2 active therapy and designed for my body in medicine. It's a large representative study sample and ratio diverse. It's a very relatively high recurrence follow-up rate in both assigned treatment group. So last year, and Dr. Lin is also another friend from North Carolina. He did the pragmatic study. So you can see he studied 14 sites supported by Arthritis Foundation. So he find Tai Chi, the different sites, and 14 sites also for arthritis. But his arthritis is not really osteoarthritis. He also studied different maybe, and rheumatoid arthritis include everything. So he also found the significant improvement pain, fatigue, stiff maintenance. With my early career, we studied rheumatoid arthritis. So it compared the control and American College of Rheumatology criteria, 20% improvement in rheumatoid arthritis. I just, because this study very small, 20 patients, I'm not going to discuss the further detail. So Peter asked this question. I like Peter, this paper. And why do we really know about safety about this study? So Peter's study and Peter Groy's study similar like and we find Tai Chi is very safe, enjoyable. We never find from any trial find serious adverse events. So this confirmed Tai Chi is really safe study from our 5 or 6 clinical trial. So I also learned this from Peter about the multi and active ingredient of Tai Chi. Why Tai Chi works? So this is our next step, because the NCCH and the next 5 years plan, the first objective is to study fundamental science. Why Tai Chi works? What we do, we learn this from clinical trial. So there's many, and my colleagues study function capacity, balance, and bone health, and neuromusculoskeletal and the field, also cardiovascular exercise, mindfulness, psychological function, and logistic effect, immune response. So, and this Peter's and beautiful and pictures and by multi-component study. So we try to understand each field, and in 2 years ago, we published with Dr. Michael Irvin, published My Body on the Immune System, and this paper takes me 7 years published with study. So I'm doing stuff very slow. Other people, do very fast. I'm doing stuff very, very slow. Takes 7 years published paper, we find, and Tai Chi has some anti-inflammatory role for say reactive protein decreased. So also we did Dr. Kong with this MGH. We did a neuroimaging study, and we presented American College of Rheumatology prepared paper. We do find the Tai Chi modulates wrist state function connectivity and cognitive control network in fibromyalgia. So now I'm going to invite my two and excellent colleague and young scientists to present their work about how to explain the mechanism of Tai Chi. Dr. Lee.
Thank you. I'm just going to briefly discuss 3 different studies that I did under the mentorship of Dr. Wang here. And all 3 of these studies focused on mindfulness and its potential role in osteoarthritis, specifically knee osteoarthritis. By the end of these studies, my hope is that you have better understanding of whether mindfulness could be a potential mechanism of Tai Chi, and also what relevance, if any, mindfulness as a construct has in this patient group. So in this study was a cross-sectional analysis of mindfulness in the study that we did in knee osteoarthritis. In all 3 of these studies, actually, that I'm about to present, we used the 5-facet mindfulness questionnaire. For those that don't know, it's a self-report outcome that measures not only total mindfulness, but the 5 different facets of mindfulness. And those are specifically observing, describing, acting with awareness, non-judging, and non-reacting. So that kind of gives you some clues as to what the definition of really mindfulness is. I suspect a lot of folks in this room already know. But mindfulness is typically defined as the ability to focus your attention in the present moment without reacting or judging. So all 3 of these studies was on a specific subset of folks in our trial that had 204 participants, and in this subset it was about 86 some odd participants. So again, in this study, we wanted to examine how mindfulness was associated with chronic pain and other health outcomes in this patient group. There's about 80 patients enrolled and about similar demographic characteristics as the parent trial. So what we found is really that higher mindfulness was associated with lower stress and lower depression, and there's some other psychological constructs that mindfulness was associated with. What we didn't find, however, is that mindfulness was not directly associated with pain or any of the other sort of physical constructs that we measured. So that was sort of opposed to what we had initially hypothesized, which is that we thought mindfulness would be directly associated with chronic pain. And then of the 5 facets, there are 3 in particular that tended to be more frequently associated with health outcomes, more so than the others. And those 3 specifically were describing, non-judging, and the acting with awareness facet. So what we also did in this study is we looked at sort of higher order indirect associations between mindfulness and health outcomes. Specifically, we knew that mindfulness is widely purported to play a role in pain coping. So we examined whether or not mindfulness could, even though it wasn't directly associated with chronic pain, if it could affect the association between pain and some of the other psychological constructs. So what we found is actually really interesting here is that one of the facets of mindfulness, specifically the acting with awareness facet, actually moderated the pain and stress association. So as you can see in this graph here, at 3 different levels of pain. So this is the mean here is the medium, this medium group, and then low and high are split between 1 standard deviation above and below the mean. Folks with higher mindfulness, specifically this acting with awareness facet, had lower stress at any given point of the levels of pain intensity. So what this suggests is that mindfulness actually sort of weakened the association between pain and stress. And we interpret that to mean that, in addition to mindfulness having a direct association with the psychological health in this patient population, it could also help pain coping in this, among these patients by weakening, the link between pain and stress. So in this next study, we examined whether or not mindfulness could be a potential mechanism of Tai Chi. As Dr. Wang mentioned in that graphic previously, mindfulness is widely purported to be a potential mechanism of Tai Chi, which is, again, widely believed to be sort of a meditative movement. And the thought is that mindfulness as a construct is sort of that meditative component, the active ingredient of Tai Chi. So we hypothesized that, this is a perfect opportunity to compare two active interventions, physical therapy and Tai Chi, one that supposedly has mindfulness as a mechanism and one that supposedly does not. We hypothesized that mindfulness would increase more so in the Tai Chi group than in the physical therapy group. So that was the purpose, and again, we used the same mindfulness, the FFMQ questionnaire. And actually, to our surprise, actually mindfulness not only did not increase more so in Tai Chi than PT, but it actually didn't really change from baseline. So this was, again, a 12-week intervention, and as you can see, there was really no significant change really in either group, and this goes for both total mindfulness and also the facets of mindfulness as well. So this is actually a bit surprising for us, and due to time constraints, there's actually some hypotheses that we thought of that could potentially explain this finding that I'm more than happy to discuss with you afterwards. But we thought this was a bit surprising, and so what we conclude from this is that over a 12-week period anyway, even though the patients got better over time, they got better in their pain, their function, their psychological health, really their mindfulness didn't change. And so mindfulness as a trait anyway didn't appear to play a role in that change. And then in this final study, we examined whether or not mindfulness had any prognostic value in this patient population. So this is, again, looking at mindfulness associations. And the reason why this is important is because patients with knee osteoarthritis are a really heterogeneous group. They're really different. The standard of practice for this patient group in terms of conservative management is exercise interventions. But we also know that not everyone gets better. Some folks get better and some folks don't. And so what's really important in this field is to examine phenotypes in this patient population to figure out why some folks get better from exercise intervention and why some patients don't. So we wanted to see whether or not mindfulness had any prognostic or predictive value in terms of being associated with treatment response, regardless of what intervention you got. And treatment response in this case was defined according to a widely accepted and validated response criteria that was developed by the Osteoarthritis Research Society International. And essentially, in one sentence, it's essentially improvements in anywhere between 20 and 50% improvements in pain, function, or global health. So that's sort of how response was defined. Again, in this study, what we did is we took all the participants at baseline and we stratified them into 3 different tertiles of mindfulness, higher, medium, and lower. And the higher group had a really high level of mindfulness, so around 160 was the average. The middle group had about 140, and the lower tertile had about 120. So what we found is that actually the higher mindfulness group was 38% more likely to achieve that response criteria than the lower mindfulness group. And when we looked at the facets of mindfulness, it really seemed that this association was primarily driven by the acting with awareness facet. So specifically, we found that the medium acting with awareness facet was 46% more likely to respond than that lower facet. The higher facet was also more likely to respond, but those results didn't meet statistical significance. So we thought this was a really interesting finding. What we infer is that mindfulness could have prognostic value in this patient population. And also, because folks with higher mindfulness tended to be more likely to respond, we speculate that it's possible that mindfulness cultivating interventions, whatever you do to make folks more mindful, could be used as a preparatory adjunct to the standard of practice right now, which means that if we gave somebody a mindfulness intervention and increased their mindfulness, perhaps they'd be more likely to respond to the standard exercise therapy that they get. From all 3 of these studies, we now have a better idea of whether or not mindfulness is relevant as a construct and what its associations may be in patients with knee osteoarthritis. And we also have an initial indication that perhaps trait mindfulness may not play a role as a mechanism of Tai Chi in this patient group. So next up, I'm going to sort of introduce Dr. Kieran Reed, who's going to discuss some of the work he's done as well. Thank you.
Thank you, Dr. Wang, and also Dr. Lee. My name is Kieran Reid, and I'm based across the street from Dr. Wang at the John Mayer Human Nutrition Research Centre on Aging at Tufts. And my background is in exercise physiology, and I did a doctoral degree in clinical research, and I just wanted to introduce you to some of the terminology and the area that I did for my doctoral research, which was focused on lower extremity muscle power. And part of what I did for those projects was to argue that muscle power is a far more critical neuromuscular parameter for older adults when we compare it to traditional measures of muscle function. Traditionally, people think about a measure of muscle function as muscle strength. So what we've been trying to do in our lab is actually demonstrate some of the importance of actually measuring muscle power and its clinical utility. And by definition, lower extremity muscle power is defined as the product of muscle force multiplied by muscle contraction velocity. Muscle strength is typically just defined as muscle force. And the reason why we're arguing that this is a much more important neuromuscular parameter, especially for older adults, and when I say older adults, this is people who are aged 70 and above. Across the lifespan, when you compare it to muscle strength, muscle power declines earlier and far more precipitously than muscle strength. And similarly, when you look at very important measures of functioning for older adults, such as the ability to walk a quarter of a mile, muscle power explains much more the variance than muscle strength. And similarly, for habitual gait, a 4-meter walk performance, muscle power explains, again, more of the variance. So we really have led this argument to actually put forward that muscle power is a key pathway driving age-associated disability. So there's some impairment at the level of the muscle, whether it's a loss of motor units or changes in fiber types. This leads to a muscle power impairment, such as reduced velocity of contraction or reduced force. And we see this as a muscle power impairment when we measure it on an apparatus. This impairment translates to a functional limitation, and a functional limitation for older adults could be having extra difficulty getting up out of a chair or being unable to go up a flight of stairs, which requires a lot of muscle power. Ultimately then, this leads to disability or a change in societal environmental role for older adults, which is a big, big problem we're facing in an aging population. So all this taken together, we've had the opportunity to collaborate with Dr. Wang and for the first time really look at the role of muscle power in a clinical population such as those afflicted with knee osteoarthritis. And this was a cross-sectional study we did based on the baseline data from the comparative effectiveness trial, where we showed that actually muscle power was an independent predictor of pain and also of quality of life, and this was also compared to muscle strength. So when we put them in the models, muscle power was the independent physiological determinant of pain in this population. And this was cross-sectional data, and in that same trial, which is the long-term Tai Chi and physical therapy trial, we could also show that in response to Tai Chi, you actually get a significant increase in muscle power. You also have a significant increase in muscle strength. Both of these deltas correspond to about a 10% increase, and we know that in older adults, a 10% increase in muscle power is really recognized as clinically important and clinically meaningful. But this study is showing for the first time that actually Tai Chi somehow is targeting muscle power or improving muscle power, and this really has important ramifications for older adults. And finally, I just wanted to wrap up by saying some of my next steps in collaboration with Dr. Wang, and also want to hopefully talk to Dr. Wayne about this, is really to move away from the sort of physiological investigations that I've been doing in the lab, and also examine more of the mind-body effects of Tai Chi, specifically in older adults, but also specifically in older adults who are at elevated cognitive risk in the community setting. I've got some preliminary data from a pilot study in a senior centre showing that when you go to a real-world setting, you can improve many, many important outcomes for older adults. And this was an improvement in executive functioning with traditional exercise. So the next steps that we're going to be working on, hopefully, is to examine the effects of Tai Chi in a real-world community setting, targeting frail older adults at risk of MCI and cognitive impairment. So that's our next steps, and hopefully we can talk over coffee. Thank you.
So after all this mechanism and exploration, our main focus is our patients. So let's see what our patients said about our study, because our objective in improved healthcare. Let's see what the patients said about this study.
Grateful for the whole team. I don't know how much I can thank you, but when I came in, I don't know whether Anna remembers or Dr. Wang, but I was a total mess. I had all kinds of stuff you can think of. I was 18 out of 18 points, trigger points. I had everything you can think of. I had anxiety, depression, anything you can think of. But anyway, all in all, I'm much better. I'm not anxious anymore. I have no depression anymore. I'm more grateful for everything in life, and I wake up every single day and thank God for medication. I used to take medication to wake up. I used to take medication to go to sleep, medication to stay alert. I don't have to take medication for anxiety. I don't have to take medication to go to sleep and to stay alert. So 3 medications are gone. I'm so grateful for the
I
time.
have more energy. I'm sleeping better. I'm walking better. I still have some issues with my knee that will have to be resolved, but I'm still able to do so much more than I could. And I feel Dr. Goldenberg for years. He is a rheumatologist, and he is involved with this study as well. And he is the person who referred me here. So I'm very thankful for him for doing that. And I recently had an annual visit with him and discussing the Tai Chi and how helpful it has been, and his follow-up checkup. We both agreed. I have really moved beyond needing to go to see him for the fibromyalgia. He said, your fibromyalgia is really such.
Okay, so let's look at Mary's story. Very beginning, I mentioned Mary. Mary's 6 months follow-up, and he told us continue practice Tai Chi and pain relief for fibromyalgia-related area, and increase physical function, improve energy, reduce anxiety, improve sleep, no headache anymore, and he pain medication and reduced Advil once a week. And her primary care physician at Lehigh Clinic for 7 years, so impressed with my improved condition. On all levels, she asked me to share Tai Chi experience with other patients. So this osteoarthritis from Jack mentioned he still and postponed his knee surgery. So the rheumatoid arthritis was still with us for also so many years. Still, this very beginning, and still we mentioned the day-to-day pain has diminished. I feel stronger than I ever feel as a teenager. Usually, I present this. My colleague said, "Do not present this. This is like and the dodo story, and it's not scientific. But I just want to share with you. Okay, what is clinical implication? Patients really seek the chemotherapy, and the safe, enjoyable exercise, high-intensity Tai Chi is effective for treatment of chronic pain, and Tai Chi also improve function, sleep quality, depression, quality of life, because Tai Chi instructor is challenging. We really need the patients and people instructor working patient population. So the challenge of Tai Chi research right now, I know Peter did a lot of the large study and really world study. So I should learn from there and develop standard Tai Chi program, a proper control group, establishing multidisciplinary program. So we sent all the NCCH for support our study. Also, people asked, why you do this? So the first picture from my mother. My mother is a physician, and he did many years for complementary integrative medicine. I follow her step. So the second is me with all the whole rheumatology and Center for Integrative Medicine. I really appreciate opportunity to share the information with you. The purpose is, again, we really like to listen your comments and feedback. This is flower from our patients from control group, not Tai Chi group. Thank you for your attention and welcome question. Yeah.
And before that, thank you guys for such a fabulous presentation, really comprehensive and very multidisciplinary. Thank you.
Hi, thank you very much. Very interesting. I think this would be for Dr. Reed. Intuitively and common sense, I understand how mindfulness could have all of the effects that have been proven in the studies with Tai Chi showing improvement, because of the also improvement with depression and a lot of the concomitant factors. What I found startling and sort of hard to understand is the finding where the muscle power associated with Tai Chi makes a significant difference. So my question is, can you, on a purely musculoskeletal or mechanical basis, explain how Tai Chi affects the joints in the movements of Tai Chi versus physical therapy? Are they different? Are they the same? Is Tai Chi sort of like physical therapy plus mindfulness? Or is it working differently than physical therapy that would explain this increase in muscle power, which I find counterintuitive?
Thank you. It's the same question we're kind of batting around ourselves. What we think is that Tai Chi is really a dynamic, rhythmic movement, which really gets at the mechanisms of driving the muscle power increases, rather than a static rehabilitation program that typically the physical therapy is. And what we're hypothesizing is that the muscle movements and the dynamic postures that you get in when you do Tai Chi, that this is actually really nurturing these changes and driving these changes in muscle strength, and in particular the muscle power. It hasn't been looked at before, but that's what we're at least thinking. Typically, when you want to improve muscle power, you have to train specifically to improve muscle power, and that's like a principle of any exercise training, traditional exercise training program. You train for what you want to improve. So in other words, you have to do your movements very, very quickly and fast and dynamic to increase muscle power. That's what we do in the lab, but we've never really seen this before with Tai Chi. So something else is perhaps going on, that there's more neural coordination. It's really kind of resetting some of the neural networks that potentially activate the muscles better, or the motor units, and we're seeing this kind of clinical improvement in muscle power. What I would say is that you don't get that, at least in this study, you don't get it from physical therapy, which tends to be a little bit more formulaic and standardized and less dynamic, I suppose. So.
Helen?
Just a follow-up to that question. So just following that argument, would a muscle biopsy, would you predict that muscle biopsies would not show any differences, that this increase in power is not at the actual muscle molecular or cellular level?
I would predict you might see some changes at the level of the fiber. From our work where we've done muscle biopsies in older adults, it's very hard to really tease out anything from a muscle biopsy with depending on the sample sizes and some properties of the biopsy. But I would speculate that you actually do see changes at the level of the muscle fiber, and that would actually allow you to separate the systems. You could actually separate the neurological system and just purely look at muscle, which would be a really, really key way to investigate and answer that question better. So.
And there is a little bit of data to suggest that the neuromuscular sequences and the links between these different joints and tissues is perhaps more efficient after Tai Chi training. So it's not just local as well. So there's that hypothesis.
So I have a question for Dr. Wang. Do you suspect that are there differences in the Tai Chi interventions when you saw the replication of findings between the different groups? Were there differences in the series of postures? And how, and maybe the corollary on the clinical side is, just as there's an emerging field of yoga therapy where there's a customization of postures for the clinical condition, how far are we from that, where there's a customization of Tai Chi postures, where you have Tai Chi therapy in a similar vein?
It's a great question. And I'm just going to want to add up. The two studies, and Augustine and Dr. Reed mentioned about, this is osteoarthritis study. Because for our study, osteoarthritis, we did a little bit different than fibromyalgia. Why? Because the osteoarthritis, because we try to emphasize lower extremity muscle function. Tai Chi also called balanced and based exercise. So people use lower extremity more, and so because our design program, we little bit has emphasized. For fibromyalgia, it's a little bit different. We had tried mental health, tried fibromyalgia. This why at the very beginning I introduced why the differences. So this different emphasis. So this reason is not everyone. You have learned this program. If you want to improve the osteoarthritis, fibromyalgia, you have from our program to understand what we're doing. Yeah. So this is a little bit different, but principle is same. Yeah.
Okay, I'm gonna see if we can get two quick questions in. Thank you.
Thank you. So on the note that you had on there that the best results are going to be from someone who has at least 5 years of practice with patient populations, I would love to be connected with a list of programs that we could connect people with in the area. I recommend Tai Chi, and I don't know where to send people. So if you have that, I would love to see that. And then you stated very clearly that it's used as an intervention, but I wonder if there is any data looking at injury prevention and recovery in athletic populations that are younger than the mean for the studies that you reviewed.
Yeah. So the last question about younger injury population, one of my colleague and Dr. Jeff Driven, and he's studying this field, the younger population and the prevention. This is his field. I mean, the future can invite him come over to present. So for Tai Chi instructor, why in the 5-10 years experience, I try different people. I interview many Tai Chi instructors around Boston area. And so I choose one of the beautiful Tai Chi and the performance, and he's a Tai Chi champion, able to come to talk with patients, but he doesn't know how to interact with patients. He just perform beautiful movement. We not need some Tai Chi champion. We need people really interaction, understand the patient, real care patients. I find that I only work with 2-3 sessions. I fire him. Yeah, because it's very hard, because it's very difficult, He's very angry, but he's a beautiful performance. We don't need that, These are the treatments, again. Yeah.
Great. Yeah, last question.
Last question, okay. Follow-up question regarding leg powers. So, first of all, I want to ask what type of Tai Chi you use it in your experiment? And then more specifically, what movement you use it?
Maybe Chenchen, you could describe the Tai Chi.
I just mentioned about what type, this young style Tai Chi.
Yeah.
And I just mentioned what kind of...
I think I missed the first part of the presentation.
Yeah, so that was
I'm sorry.
Yeah. And it was a very a simplified form that was adapted for people with lower extremity pain, but nothing fancy, nothing dynamic. So I think Kieran's results are quite provocative, because unlike traditional muscle power testing, you still see this result in a much slower, controlled set of movements.
So is how many movements? 8?
I think this is a really good question to ask these guys afterwards, because I think it's very specific, and we're going to have lots of time, so this is a good segue to the end, and I want to respect everyone's busy schedule. So afterwards, you're all invited to a coffee hour here to ask further questions and to get to know each other and network. So I want to make sure that you take advantage of that. I also want to alert you to our next seminar. Michelle Dossett, who's here today, Dr. Dossett from the Benson Henry Institute, is going to be presenting a case study on atrial fibrillation. Is the intervention the mind-body program offered at the Benson Henry Institute. So I'm sure it'll be a really great presentation, and she'll come with a number of colleagues and discussants. So please join me in thanking our speakers one more time, and I thank you all for being here.